So welcome all for our today's episode of Gurukul Pathshala, the PG teaching classes. So today we have an innovative idea that we don't want to go for the approach to congenital heart disease or approach to something cyanotic heart disease or acynotic heart disease. We wanted to see by the case-by-case discussion that how this cyanotic, acynotic will be important in the pediatric patients and how the PGs will learn it. So with this innovative idea, we are going for today's panel discussion. For this today's episode, I welcome my President, Dr. Jankna Madam, for her welcome address.
Thank you, Dr. Nehal. Good evening, everyone. I warmly welcome today's moderator, Dr. Neeraj Agarwal sir, and a panelist, Dr. H. Ravi, Dr. Kaur, Dr. Divyesh, and Dr. Murtaza Kamal. I welcome our Honorary Secretary, Dr. Nehal, and Program Coordinator, Dr. Lata. Today's panel is cyanotic disease versus cyanotic disease. Let's learn how to decode this cyanotic versus acynotic disease with extremely talented moderator and panelist. I know after this panel, we all feel contented about the cyanosis versus acynotic disease, overall this congenital cyanotic heart disease. Not taking much time, over to Nehal, please.
Yeah, thank you so much. With this, we have in today's panel discussion, Dr. Jalil sir is there. Welcome, Jalil sir. And also Dr. Ashwini Agrawal sir. These two stalwarts are there who has joined us for today's panel discussion. Welcome, Ashwini sir. For further introduction of today's panelist and moderator, I am handing over to our program in charge, Lata.
Good evening, everyone. Thank you, Nehal ma'am, for your kind words. So today we are going to have a panel discussion with topic cyanotic versus acyanotic. Does it still matter clinically? So moderator for today's program is Dr. Neeraj Agarwal sir. He is Director of Pediatric Cardiology at Sir Gangaram Hospital, Delhi. The panelists for today are Dr. H. Ravi Ramamurthy. He is Professor at AFMC, Pune. Dr. Jasleen Kaur ma'am. She is a Pediatric Cardiologist at Sir Gangaram Hospital, New Delhi. Dr. Divyesh Sadadiwala sir, he is at Happy Hearts Clinic, Ahmedabad, and Dr. Murtaza Kamal, he is at Rainbow Children Hospital, Hyderabad. Welcome all the moderator and the panelist. Over to you, Neeraj sir.
So thank you so much, Lata, for a wonderful introduction. All the panelists, believe me, if I take that full CV, the whole session will be completed in their introduction only. So we have just taken their designations and not went through all the CV. Thank you so much, but you will see the expertise of all of them in today's session. So all yours, Jasleen and Neeraj.
Sure, ma'am. The screen visible?
Yes.
Yeah. We can see your screen.
Wait, I'll just share the PPT. Yeah. It's visible?
No, it
Not
it
visible.
was visible initially, not now.
Okay. Just a minute.
Yeah, it's there.
Now it's visible. Okay. So till the time sir joins in, we'll start with the topic.
Jasleen, it's not full screen, but.
Yeah, ma'am, make it full screen, please.
I'll make it.
Hmm.
Now it's full screen?
Done.
Okay.
Yeah.
So we'll start with the discussion topic about clinical cyanosis and pulse oximetry. Whether these two are associated, whether it is very essential to see pulse oximetry or only clinical cyanosis is important. How to classify the congenital heart disease based on cyanosis. How do we classify them? Like we have a TOF physiology, that is cyanotic heart disease with decreased flow, a cyanotic heart disease with increased flow. We have a mixing physiology, and then we have drug-dependent pulmonary flow. So first of all, some words about cyanosis and deoxygenated hemoglobin. What are they? So the amount of deoxygenated hemoglobin, which is required to produce bluish discoloration, so hemoglobin should be at least 4 to 6 gram% or more. That means in a normal person, at least the oxygen saturation should be 80 to 85% with a hemoglobin of 14 to 17. As and when we go and the hemoglobin decreases, as in case of severe anemia, the deoxygenated hemoglobin required is more. That means in a normal individual, we see cyanosis at 85%. In a patient with anemia, we required a saturation of 62% to see cyanosis. In a polycythemia, we can even see cyanosis at 87%. So, for a cyanotic heart disease or for a cyanotic patient, if the patient is having normal hemoglobin, 85% saturation is enough to see a saturation, to see cyanosis. But in anemics, we cannot see saturation, the cyanosis so often with this hemoglobin. So we have certain questions to answer in a suspected congenital cardiac heart disease with cyanosis. First of all, the first and most important question is whether the baby is having a cyanotic heart disease or acyanotic heart disease. Now, when we classify this, that the patient is having cyanotic or acyanotic, the next question appears whether the pulmonary blood flow is increased or decreased. And then the third question, whether the patient is having duct-dependent circulation, which can be either duct-dependent pulmonary circulation or duct-dependent systemic circulation. So we'll start with the questions for the panelist. So the first question is it possible to see cyanosis clinically in all the cases? So this question is for Dr. Murtaza, sir.
Yeah. So a very nice question, which we all as clinicians have to understand this, that cyanosis first day, as has been just emphasized by Dr. Kaur, that it is a clinical diagnosis. So it will be seen by our eyes. So we have normally a particular cutoff that below 85% only we can see cyanosis. But we all know that the normal saturation is more than equal to 94%, which is very important. So the gap between 85% to 94%, our eyes cannot see, but it's not in the normal range. This basket of 93% to 85% will be pushed towards something towards cyanotic only, because when we are classifying the diseases as cyanotic congenital versus acyanotic, this basket will be pushed from 93 onwards towards cyanotic only. So this is something like arterial desaturation in this range, in which although the eye is not able to pick up cyanosis, but their child is cyanotic. There can be some other situations, like if the child is like the person's skin is dark. So in those cases, the picking of the cyanosis will be very difficult. Another case which has been just highlighted by Dr. Jasleen was that if the child is anemic, so we need a particular amount of desaturated hemoglobin in the form of like 4 to 6 gram per deciliter, as has been emphasized. So if the child is anemic, like his hemoglobin is just 7 or 6, so to get that amount of desaturation, like to get that amount of deoxygenated hemoglobin is difficult. So cyanosis won't be evident easily in the case of anemia. So these are some of the conditions in which it is difficult to detect cyanosis clinically, basically.
Thank you so much for highlighting this so nicely. So the next question is it possible that the patient is not having clinical cyanosis, but still having a cyanotic heart disease? So this is the similar question, other way around. So this question is for Dr. Divyesh.
Yeah, I think it overlaps with the last question
Yes.
only. As Murtaza sir said, that our eyes are not adjusted to differentiate between that minimal range of 85 to 93%. I will add some factors to this. If you are in busy clinical OPD, you are not able to see proper sunlight is not there. Patient is having cyanosis, but you will miss this minimal amount of desaturation. First thing. Second thing, many a times it happens in girl child that their nails are polished, so will not be able to appreciate the cyanosis in those girls. Third thing I would like to mention is the cyanotic CHDs with increased pulmonary blood flow. So they are having borderline desaturation, and patient will be having more symptoms of congestive heart failure. So it is very easier to miss cyanosis in this kind of patients when patient is having distress, patient is having failure to thrive. So your eyes are diverted towards a factor towards the CHDs like large VSD, large PDA. and you will easily miss the desaturation. Sometimes it happens that some abnormal, some very rare anomalies like left superior vena cava is attached to unroofed coronary sinus. So many times we see that along with acynotic CSD, there is an anomaly called LSVC2 unroofed CS. In those patients also, we will miss this kind of borderline desaturation. So yeah, these are the possible causes that cyanotic CSD is there, but you will apparently not see a clinical cyanosis in these patients.
Yes, sir. Very well said. So just to summarize, can Dr. Ravi, sir, just summarize all this for our students? What are the factors in which a cyanotic congenital heart disease presents without cyanosis? Like we cannot see that cyanosis, but actually the patient is having cyanosis without pulse oximetry. So can sir just summarize those factors for our student?
Sir, you are mute. Ravi, sir.
Yeah, for our enthusiastic pediatricians, I'd like to put it up like a short note, how you are used to having answers. One is patient factors. Okay, patient may be anemic, most important. Second, it may be a congenital heart disease which has got very good admixture. So it's not causing too much of cyanosis, just desaturation. Patient factors, one, patient factor two. Third is patient factor, patient social factors, like patient putting nail polish, patient putting lipstick, or the patient is, you're seeing in a hurry, the patient is in a hurry. Sometimes they just want to come for a consultation, especially we find among, second, third decade, premarital consultation for a young girl. Somebody just wants to come and see, get a checkup done. So you're in a hurry, they are in a hurry. Then comes the doctor factors. Doctor's in a hurry, you miss it. Secondly, if you're just as Dr. Divyesh has put it across, if your lighting is poor or you're not examining properly in such situations. So you have to remember there are certain patient factors and there are certain social and doctor factors for which you can miss them. But for patient factors, we have to seek out. It's our job to go and seek out and eliminate the doctor factors of missing cyanosis. At the end of the day, your job as a pediatrician is to pick up even the mildest and minutest of cyanosis.
So sir has explained very nicely like a 10 marks question, and whosoever will write it will get 10 on 10 for this.
I would just like to put a note here that many pediatricians are following this habit that like we take height, weight. Many pediatricians have started developing this habit of noting saturation of each and every patient.
Yes.
So pediatric cardiologists by default do this thing. But if pediatricians start doing this practice, then there will be very less chances that you will miss cyanosis.
Yes, sir. So now it's called the fifth vital, the saturation.
Correct. Yes.
Apart from the four
Very
vitals, this also needs to be done.
Yeah.
So the next question is for me, that is neonatal pulse oximetry, the screening guidelines. So first of all, before the screening guidelines, we should know in which patients and when we should do it. So it is performed after 24 hours of life, from 24 to 48 hours, but before the discharge of the baby from hospital. Because before 24 hours, the transitional circulation is there. So it may be overlapping, but from 24 to 48 hours and before discharge from hospital, this should be done. First thing. Second thing, the probe should be in preductal and postductal position. So what is preductal? Preductal is right arm and postductal is either of the lower extremity. Now, why preductal is right arm? So this is just from the anatomy, the arch of aorta. The right side has the innominate artery, giving rise to right subclavian and carotid. Then second is common carotid and third one is left subclavian. Now the duct is just juxtaductal to the subclavian. So it can be missed. The saturation can be missed if we take on left arm. That's why we take right side, because right duct, the duct and the right subclavian are very far off. So we are very sure that we are not taking saturation from the duct or from the lower part. That's why the preductal is always right arm. And for the lower extremity, either of these we can take, because it is just the descending aorta we are taking. So these two things should be done. Now, when do we call that the screening is failed or the test is positive for this pulse oximetry? So these guidelines are AAP guidelines for newborn screening for CHD, which is given in 2016. So according to this, if the saturation is less than 90% in any of the limb, that means in either right arm or either of the lower limb, then the screening is failed. Or if the saturation is less than 95% in both extremities, and we have taken 3 readings 1 hour apart. Or if there is more than 3% difference between upper limb and lower limb, Again, we have taken 3 readings 1 hour apart. So if either of these is present, then we call that the neonatal pulse oximetry screening is failed or it is positive. So we have to consider
Dr.
for
Jasleen,
echo.
Dr. Jasleen,
Yes, sir. Sir is joined. Yes, sir.
and RR sir is also around. So, I have some different take on this. Like,
Okay,
suppose
sir.
my saturation is less than 90, but it's 80%. Then I'm not waiting for 3 readings. Understand this part.
Yes,
So if my
yes.
saturation is too less,
Hmm.
80%,
Then we can't take.
75%,
Hmm.
then I'm not waiting for 3 readings separate. I'm not wasting 3 hours.
Yes,
So
sir.
I'm not wasting
True.
time in those cases. RR sir, what is your take on this screening protocols? RR sir?
I think sir is on mute.
Sir, you need to unmute.
Yeah, sorry. I just want to cut out the ambient noise, but I forget to unmute myself.
Yeah.
So rightly said, sir. If the child is either the SpO2 is very low, if it is clinically cyanotic, you can see clinical. Now we go back to the first slide again. That if this is a clinically cyanotic baby, I don't think we need to actually just send for an echo before you make these 3 readings of SpO2. You can say clinical cyanosis is enough indication. This is for the normal looking babies.
Yes.
This is for the normal looking babies. I want our people, all the audience to remember that if you have a blue baby, just send across because you can't waste
Or
time.
the
It may
sick
be a
child.
dependent.
Or the sick
Huh,
child.
sick
Or a sick
or
child.
extremely newborn.
Extremely
So,
sick child.
yes.
So for a healthy
Yeah.
looking newborn, this is the guidelines.
When you are in doubt,
But-
because 90% saturation you can't pick up by eyes only.
Yes.
So for that you
Dr.
need
Baldev
screening.
sir has a comment now. In the chat box, we have a comment from Dr. Baldev sir. Over detection of cyanosis dilemma may be due to blue curtains in the room, blue color of the walls. So blue color can cause over detection of cyanosis. That should be kept in mind. And my practice, I see a lot of peripheral cyanosis being said to have a cyanosis, which should also be decided that I am talking about central cyanosis, not peripheral cyanosis. Peripheral cyanosis is very common in the newborns. We all know that part. So we can move to the next slide. Jasleen, yeah, okay. So this is like we're talking about when we talk about cyanotic versus acyanotic heart disease. We're talking about central cyanosis, not peripheral cyanosis. And in some cases, we're talking about saturation being less than 94%. Like eyes are not picking up cyanosis, but my saturation is low, that is also cyanotic
Actually,
state.
saturation.
And then that's why pulse oximetry is very, very extremely important to detect cyanosis. Next slide, just take care of that. So RR sir and DS both are there with us. How do we classify cyanotic CSD clinically? Can we define cyanotic CSD groups into clinical parts?
Divyesh, you can start up.
Yes, sir.
Yeah.
We can classify cyanotic CST
Yes,
based on
yes,
pulmonary blood flow. So we commonly know the cyanotic CST with decreased pulmonary blood flow situation. The prototype of that will be tetralogy of Fallot, and all the pulmonary stenosis physiologies like DORV, VSD, PS, TGA, VSD, PS, single ventricle VSD, PS. So all these anomalies will come under that etiology, pulmonary atresia, Epstein anomalies. And increased pulmonary blood flow situations, Dr. Ravi, sir, you will take it.
Yes. So now as we, okay, I'm unmuted. So as we can see, simply we have to think in 2 situations. When it's cynosed, first, is the lungs getting blood or lungs are not getting blood? Or if the lungs is getting less blood or lungs is getting more blood? So the ones who are getting more blood is increased pulmonary blood flow. They won't have the PS suffix to their whatever disease they have. Whereas the one which have got decreased pulmonary blood flow, whatever would be the lesion admixture or combination of lesions, will have the suffix of PS, pulmonary stenosis. So again, to remember it very easy, all those things on the left will have PS as a suffix. TGA VSD PS, DRV VSD PS, tricuspid atresia VSD PS. When you look at the reduced pulmonary, normal increased pulmonary blood flow, there will be no PS, or we cardiologists call it a PAH physiology, because the pulmonary pressures are on the higher side. So this has got a therapeutic implication, which we'll not discuss now, but you remember that clinically, if the baby has got failure, see features of failure, failure to thrive along with cyanosis, then it becomes a high pulmonary blood flow cyanotic heart disease. Whereas if the baby has got no features of failure, but has cyanotic spells, deep blue cyanosis, but silent precordium with a murmur, then they all are indicative of a decreased pulmonary blood flow, which prototype is TOF. Prototype is tetralogy of Fallot. So this is what you need to remember, that the suffix PS comes to decrease pulmonary blood flow. The same lesions may not have PS, they're all increased pulmonary blood flow.
To add in, as Ravi sir has told, for students, I'll just add a slide for it. So whenever you are asked to classify the cyanotic CHDs, make it into two parts, and we can add one more. Those with decreased, those with increased, those with near normal. So as decreased, we have talked about two types of physiologies. Basically, one is obstruction, a VSD PS physiology, like which will have TOF, DORV with a large VSD PS, TGA with a large VSD PS. Remember that the VSD will, in those cases, all will be large, unrestricted, and there will be PS. The second subset in decreased pulmonary blood flow is the Eisenmenger's physiology. The distal pressure is high. Due to that, the pulmonary blood flow is decreased. Coming to the increased pulmonary blood flow, you can again divide it into two parts, those with admixture physiology and those with transposition physiology. For basically admixture physiology, you are mixing the blood. Basically, it can be inside the heart, it can be above the heart, it can be below the heart. So above the heart, it will be admixture at the level of great veins, which can be a TAPVC. At the inside the heart, it can be at the atrial level. So there is like tricuspid atresia, and everything of the right atrium has to go to the left atrium, and then the things will be supplied to the whole body. Or a hypoplastic left heart syndrome, same way. Coming down to a single ventricle physiology, admixture at the ventricle level. Coming further above the heart is like transposition. So basically, the mixing is occurring at the great arterial level. Coming to the TGA physiology is very simple. You have a DTGA. In this TGA physiology, basically, there will be unprotected pulmonary blood flow. So there is no PS associated with that. TGA with a large VSD PS comes into the basket of decreased pulmonary blood flow, TOF physiology basket, whereas this is transposition or a TOSIC big anomaly. The third category is near normal pulmonary blood flow, as Dr. Divyesh was highlighting, like something going into the right atrium. The thing which was supposed to go into the right atrium is going into the left atrium, like the SVC, draining anomalously to the left atrium, or the IVC, or a coronary sinus, which was unroofed and it is giving the desaturated blood into the left atrium and desaturating the things.
Dr.
Yeah.
Murtaza, that will come in the next slide. So we
Okay.
let the audience soak in with this information, and then we move on to the next slide, because that is going to come in the next slides.
Right.
So we'll take that part for some time. So now we have a question on what is the clinical relevance, MK. Now is your understanding. What is the clinical? Why do you want to classify this into two groups? Your elaborated high flow, low flow. What do you want to know about clinical relevance? What is the clinical relevance here?
Yeah, this is again a very important question. So anything in medical science, wherever we are classifying, goes on to the management. The thing we have to understand. So basically, to divide the congenital heart diseases into like decreased pulmonary blood flows or increased pulmonary blood flow as cyanotics, or even the acynotics as shunt lesions at pre-tricuspid, post-tricuspid. Basically, we want to know how to manage it. So those with increased pulmonary blood flow, they will be presenting to us with features of congestive heart failure and all. So there will be failure to thrive, congestive heart failure, repeated respiratory tract infections and all. So we want to reduce the pulmonary blood flow so that we can protect the lungs, basically. So the strategies will be to increase, give diuretics to them, to correct the shunt lesions if they are, and if we are not able to correct, we'd like to decrease the pulmonary blood flow, maybe a PA banding and all. Whereas if it is a decreased pulmonary blood flow, our main aim will be to increase the saturation of the child, like a TOF physiology, if it is there. So in those cases, we'll be like, if there is like very severe cyanosis, we'll have to do something to increase the pulmonary blood flow, to give extra blood to the PAs in the form of like initial parts, we can do a PDA stenting or a BT shunt. But if the child has been okay, maintaining a reasonable saturation of above 70 and all, we normally operate the TOF around 9 months to 1 year. This is standard. So basically, for the treatment modalities, we want to differentiate them.
So, RR sir, your view, do you start medications based on clinical classification in your practice without echo?
Yes, sir. Yes, I'll take this question. I'll take this question and answer it in the form of a cascade. The first question of the part of the cascade is, can we start medication based on symptom chest X-ray? This is a most trickiest part for a pediatrician sitting in the emergency department or in the OPD or in the ward for that matter. Every day I deal with residents who say, sir, what do I do next? So the question answer I always give is, please do not wait for an echo diagnosis to start medications. Okay, question answer is yes, you can start medications based on the symptoms and one chest X-ray. Next question will be, what are the medications do I start? It's always a mental block. Do I start digoxin? Do I start IV fluids? Do I start Lasix? Then you have to apply your logic. If there is reduced pulmonary blood flow, there is no failure. So you don't have to treat the child with any diuretics or ACE inhibitors. If the pulmonary blood flow is increased and the patient has got failure and there is cardiomegaly on X-ray, you have to treat the patient with diuretics and ACE inhibitors. Next question would be, if the child is deeply blue, then yes, the one magic medication all should use is prostaglandin. Please don't hesitate if the sick baby, very blue, deeply cyanosed, and you know it's a decreased pulmonary blood flow, do not hesitate to start prostaglandin based on your X-ray and clinical features. So the answer is yes, and the drugs also have enumerated.
Yes, so rightly answered. Like one group will need diuresis, another group will need beta blockers most of the time. That we have to decide. But you can't start both drugs. Some people, like TOF patient, should be on beta blocker, not on diuretics. Similarly, TGA patient, with TAPVC patient, high flow patient without PS should be on diuretics, not on beta blocker most of the times. Now let's talk about some X-rays which can help us in understanding how do you talk about pulmonary blood flow. We say we have divided the group into two parts, high flow and low flow. But how do you decide the high flow or low flow? So Jasleen can take this question.
Yes, sir, sure. So, sir, as rightly said, that based on symptoms in X-ray, we can start medications. So, what on do we see in X-ray when we say that the patient is having a high blood flow or a low pulmonary blood flow? So, first of all, we have to look for cardiomegaly. So, cardiomegaly, as we already have read earlier also in our pediatric classes, that cardiomegaly is when we take the diameter of heart from the left and right border, the maximum diameter, divided by the internal diameter of thoracic cavity when we divide it. And if the ratio is more than 0.6 in newborns and more than 0.55 in older children, we call this as cardiomegaly. So first thing is we have to classify that whether the heart is having cardiomegaly or not. But keep in mind that in small units in which we have taken AP X-ray view, because these guidelines are for PA view. If you have taken AP view or if thymus is there, then we may overinterpret it as cardiomegaly. So that thing we have to keep in mind, but otherwise the guidelines is this for cardiomegaly. Now, second thing is about pulmonary blood flow. How do we classify that the pulmonary blood flow is increased or decreased? So in this, two things we have to see. First of all, the end-on vessels, and secondly, the right descending pulmonary artery. Now, what are these end-on vessels? So when the X-ray beam passes through the lungs or through the X-ray, then certain vessels are seen as an end-on, white colored. So these are small vessels which accompany the bronchus, and the size of these vessels is equal to bronchus. But if we see these vessels, which are very frequent in the middle 1/3 of lung field, which is more than 4, or if these vessels are traceable to lateral 1/3, which is more than 6, normally we don't see in lateral 1/3 of X-ray. In a normal X-ray, lateral 1/3 doesn't have these end-on vessels. But if we see more vessels on the lateral view also, this thing, or if the right lower descending pulmonary artery is equal to the size of trachea or more than the size of trachea before carina, or if this right descending pulmonary artery is equal to more than the accompanying bronchus, then we say that RDPA, the right descending pulmonary artery, is dilated. So in an X-ray, we have to see for cardiomegaly and vascularity. For vascularity, the end-on vessels, the number of end-on vessels, and the size of RDPA. Now in adults, we have a cutoff for RDPA more than 16 mm, but this is not true for children. For children, we only have to compare it with the accompanying bronchus or with trachea. Then we call it that the child is having increased vascularity along with the cyanotic heart disease.
So I agree, but go to the next slide, Jasleen. Go to the next slide.
This one.
Next, yeah. So it is very easy to understand white lung and black lungs for a routine
Gross.
test. Yeah, you see right side you have a white lungs. On the left side, just show the cursor, Jasleen. Jasleen, I will share my screen. Okay, that I think I should share the screen so that I can
I'll stop
point
sharing.
out. Hold for a second. I'm just sharing my screen. I think multiple will be allowed now. I think now I'm sharing. Is it my screen? You can stop it. I have started.
I'll stop sharing.
This is my screen. Yeah. So, this thing, you see this white lung versus black lungs. So this is high flow and this is low QP. The lungs are not getting blood. That's why, as other panelists have said, this patient will need beta blockers, and this patient will need diuretics. High flow will need diuretics. This patient will need beta blockers so that I can go up on the flow. Now, DS, what do you think about these images? Like, how do you interpret X-rays in your practice? Do you start medicines based on these X-rays? DS.
Sir,
Divyesh.
I tell my pediatrician friends.
Dr. Divyesh?
Yes, sir. Am I audible, sir?
Yes. Yes,
Yes,
audible.
Divyesh, you are
Yes, sir, you are audible.
So first thing, as Dr. Jasleen mentioned in the previous slide, first thing first is cardiomegaly. This is the basic part. Last night also I got a call about a newborn baby, and they were asking whether it is a cardiac because the patient was not maintaining saturation on 100%. So first thing I asked on phone, send me the X-ray and whether patient is having cardiomegaly or not. So after being taught routinely, very frequently, then also we almost all the times forget to see whether patient is having cardiomegaly or not. So first thing, cardiomegaly, whether it is cardiomegaly or there or not. Second thing, the very nicely put points were there in the last slide. Whenever you are looking for the pulmonary plethora, I routinely tell many people are confused. What is pulmonary plethora? How will you differentiate whether it is increased blood flow or not, or it is just a basic normal pulmonary blood flow? So I routinely tell if the pulmonary blood flow is reaching the lateral 1/3, then it is high QP. Third thing I routinely tell is whenever you are able to see right pericardiac shadow, that increase the size of the right pulmonary artery, if you are able to appreciate these 3 points, if you keep in mind, you will not miss pulmonary plethora, you will not miss high QP situations. And those high QP situations, as we have discussed, they will warrant diuretics as medicines. When we come to this part, the opposite side, so you will see cardiomegaly in these patients also, but it will be right ventricular type of cardiomegaly, first thing. Second thing, black lungs, as Dr. Neeraj sir told, you will not be able to see vascularity reaching almost half of the lung fields also. So, and third thing, as I told, as we discussed, we have not discussed the third thing, that most of the times if TOF prototype or decreased PS physiologies are there, you will not see the pulmonary bay in this kind of patients. So these points, if you keep in mind, then high QP and low QP situations are very easy to differentiate. And based on that, it is very easy to start medications, diuretics or beta blockers also.
So rightly said, these X-rays have to be kept in mind whenever you're talking about a heart disease patients. Now let's move to the next slide. So this is again the same X-rays, just to highlight, as Dr. Divyesh rightly said, this is the pulmonary conus, where you have a bay here. See, this is also important point. The rest of the points we have covered, but this is also very important point. So see this slide again. See, there is a prominent pulmonary artery conus, whereas you have an absence of bay here. It also will go low flow versus high flow.
High.
Also, sir, just one more point. We also have to add the exposure of X-ray, whether it is overexposed or underexposed. That thing
Yes.
also we have to keep in mind while reading this.
That always in all X-rays. Yes, of course, this is a very important point, especially in today's era where digital X-rays are available. You can reduce the exposures in the spot.
Correct.
So, RR sir, now we have come back to the same question again. How many clinical groups you decide now?
So again, as I said, think like two things. One, when you're sitting in an OPD, what do I do? Second is when you're writing an exam answer, what do I do? Most of the times, the answer is always the same. So how you prepare for exam is going to be an OPD. So you have reduced pulmonary blood flow when you call QP-QS as less than 1. Increased pulmonary blood flow when the QP-QS, that is pulmonary flow to systemic flow, is increased. Then there is a third situation, which Dr. Kamal was saying was near normal pulmonary blood flow. This is where the pulmonary blood flow may not be overtly increased, but it's not going to the lungs, but extra flow is going into the left side. But they're mixing somewhere. There is mixing happening someplace. So you have to remember that these are the 3 clinical scenarios which you have to deal with. Top 2, management we already discussed. Third one is very difficult to diagnose and requires additional investigation. So you don't really have to bother much because these patients are not usually very symptomatic in addition to cyanosis. So they are unknown cyanosis. They can be classified as cyanosis, not able to find a cause. And they definitely warrant a super specialist investigation. So, but the first two categories are some which you will have to manage at the first observer level, the first discoverer level. You'll need to manage them. Keep that in mind.
Dr. Ravi, sir, when do you think of like this patient can be a near normal permeable blood flow, not about two groups? Like when do you think after echo you start thinking like when do you think about this third group?
First is clinically. So these patients would not have very overt cyanosis. They may be having very on and off. Somebody would, if you go through the old documents, you will find that somebody would have documented one low SpO2 of 90, or the patient would have said that someday I was very tired and I felt extra tired. I'm getting more fatigable. These are those patients who are just little more fatigable. Sometimes they're being called lazy and things like this. They don't play for no reason whatsoever. They don't have dyspnea. They don't have recurrent infections. They don't have any other problem except they're just a little lethargic. And then somebody would have documented on low SpO2. So the first important thing is checking SpO2 and knowing that there. Then we do an echo as cardiologists. The first entry ticket is doing echo. So we do an echo and we find that strangely, this patient does not have the usual set of lesions. There is no pulmonary stenosis. There is no VSD. There is no ASD. But the thing is, we find because of our experience or the learning, there is a different chamber dilatations. They will have some abnormality. That is the status level. At the echo level, we find that this patient has got an abnormality. And when you go back to the X-ray and see, this would have corroborated. The LV would be a little more dilated. The left atrium would be a little more dilated. So the ECG and X-ray always give a clue. So as I always say to all the pediatricians, younger junior pediatric cardiologists, that never ignore your ECG and X-ray before doing your echo, because that is your roadmap and your echo will be giving you the, it is a conviction. So your ECG and X-ray would have got a clue
Rightly
of
said.
something.
Yeah, so rightly said, you are saying minimal signs like symptoms, mild signs, you should not ignore, and that should give you a clue. Now we move to the DS. Dr. Divyesh,
Yes, sir.
what is your experience with the near pulmonary blood flow, CCHD, near normal pulmonary blood flow? What do you do to, I say, Dr. Ravi says, some dilatation is there, but I don't have a cause for cyanosis. Like some dilatation will not cause cyanosis. For cyanosis, you should have right to left shunting. The blue blood has to enter the red blood. So how do you decide what disorders, how do you go about it further in your practice? Like what tests
So
you
first
do
thing,
to confirm?
first thing first, we rule out any associated anomalies when we are doing echocardiography. So after you have ruled out all the possible cyanotic CHDs, then this near normal pulmonary blood flow situations will come. So after you have confirmed that cyanosis is there, saturation is on the lower side. Second thing, your echo is normal. Then comes all these three very rare kind of anomalies, congenital heart disease. So baseline investigation in your OPD to do will be contrast echocardiography. And I routinely advocate to all my pediatrician friends also that contrast echocardiography is a very useful tool before going to any advanced investigations like CT angiography. If you are doing contrast echocardiography, last month only we did one patient who was having structurally normal heart, but only isolated LSVC to unroof CS. And patient had saturation of 88% only. We did contrast echocardiography and all the contrast was directly entering into the systemic circulation. Same way, if you are having pulmonary arteriovenous fistula, you do contrast echocardiography and you will see very nicely all the contrast bubble entering into left heart of the system. So contrast echocardiography is not routinely advocated investigation. Very frequently used. Even pediatric cardiologists have seen they have stopped using contrast echocardiography because of advancement of CT angiography, very easily available CT angiography. Nobody's bothered to do contrast echocardiography, but it is very useful investigation.
And also, the way CT scan may not pick up all three disorders.
Yes.
These three disorders, CT scan may not pick up actually. So, and
unless they're guided. CT scan has to be guided,
once,
sir.
Once we have put up the diagnosis, it becomes easier for them to.
Easy for them to.
Yeah. And also they have good outcomes. This can be surgically, this can be surgical, this can be surgical, this can be mostly in cath lab. They have good outcomes also nowadays. So
And
rightly
here I'd
said,
like to
we
also
cannot miss this.
make it a point, sir, that
Yes.
sometimes CTs can
Yes.
overreads also. There are certain
Okay.
AV malformations. I've come across 2 occasions where the radiologist has given a report of pulmonary AV malformation, but when we did a contrast again, it could not be demonstrated. And because the radiologist was very adamant, then we had to even did a cath also, and we proved it conclusively. There is so the CT tends to overread. What I'm seeing recently, sir, CTs tend to overread. That's also one factor we have to keep in mind.
Yeah, that every imaging modality would have some limitations. We have to accept that possibly and go with the clinical understanding. So, Dr. Murtaza, what are the, how do you decide groups based on symptoms? Do you have specific symptoms? I think all CSD would have dyspnea, chest pain, distress, recurrent LRTI. So all CSD have like this, but do you decide? Do you say low flow and high flow have different symptoms also?
Yeah, this is again an important point which should be highlighted and should be understood that symptoms of decreased pulmonary blood flow and increased pulmonary blood flow will be quite different, basically. So, those which have an increased pulmonary blood flow will have more features of congestive heart failure, which I was like talking at that time, which has come now. So, since there is increased pulmonary blood flow, they are having features of congestive heart failure in the form of they will be having tachypnea, tachycardia, there will be diaphoresis, they will be having like recurrent episodes of LRTIs, even failure to thrive is very important. And these increased pulmonary blood flow situation comes in both the baskets. Cyanotics with increased pulmonary blood flow situation and the shunt lesions which are acyanotic with increased pulmonary blood flow situation. So both like increased pulmonary blood situation comes in both the baskets of cyanotics and acyanotics. Coming on to those which have a decreased pulmonary blood flow, the symptoms won't be of like increased pulmonary blood flow, like they won't have a features of CHF. They will have more of cyanosis since the pulmonary blood flow is decreased. So they can have spells, features like spells. They will be having more of dyspnea or normally they will be having like even will have episodes of spells. Okay. And they can have, due to this cyanosis, many complications, which can be having CNS complications. They can have polycythemia related to those things. So the features are quite different, and it is easy to differentiate between the two, even clinically, the two groups.
So as we tell our students, remember a TOF patient here and remember a VSD patient here in terms of symptoms. Large VSD, huffing and puffing, failure to thrive will come to this category. As you rightly said, ACSD or CCSD, the symptoms are same. And this one has, and also one more thing, let's come to the science now. Let's come to the sign on examination. JK, what are the findings on examination which will help you differentiate a student that is a low flow or high flow?
So similar to symptoms, we have examination findings also. So a patient, a cyanotic patient with low flow is having more of signs, and a cyanotic patient with increased flow is having more of symptoms. So that will correlate with examination finding also. So with the low flow, we'll see cyanosis, we'll see clubbing, but when we'll examine the patient, we'll see the chest, it will be a quiet precordium. That means there won't be any sulcus, Harrison sulcus, no precordial bulge, the patient won't be restless, there won't be depression in the subcostal spaces. So it will be no tachypnea, no precordial bulge, and a normal apex pit. The only thing we'll see is when we'll examine it and we'll auscultate, then we'll find that there is a murmur. And for this murmur also, we have to see the shorter the murmur, more severe is the stenotic or the lesion. So if in a PS patient, we find that the murmur is very loud, that is a good sign because PS is not so tight. But if the child is very blue and we see the murmur is less, that means there is critical stenosis. The flow is not going through pulmonary artery. That's why the murmur is less. So with the decreased flow, we'll only see cyanosis and clubbing, and on clinically visually, on inspection and palpation, we won't find anything. Just on auscultation, we could find a murmur. Whereas in a cyanotic patient with increased pulmonary blood flow, along with cyanosis and clubbing, which will be mild to moderate, we'll see all the signs of increased flow like a VSD patient. That means there will be respiratory distress, there will be retractions, there will be Harrison sulcus, there will be active precordium, and the apex beat will be shifted because of enlarged LB. So we have to differentiate based on symptoms. Similar will have the signs also for a decreased flow and for a increased blood flow.
Yeah. So, okay, so we understand this part now. We have to move slightly faster because we're running short of time now. So, RR sir, how do you define differential cyanosis? How do you pick up, and what is the reason of differential cyanosis?
As it's brought out in the terminology, differential cyanosis. Now, the question is difference between what? As pediatric cardiologists, I always say that we think very simple. So difference is upper limb, lower limb. If there's a difference in the cyanosis between upper limb and lower limb, and the upper limbs are pink and the lower limbs are blue, this is what we call as differential cyanosis. The only reason that can happen is when there is a PDA, which is shunting the blue blood from the pulmonary circulation into the systemic circulation, a right to left shunting PDA. The causes can be anything. It can be an interrupted arch that the pink blood is not reaching. It can be a pulmonary hypertension where the pressures in the pulmonary circulation is high, or it can be whatever reason like an aortic critical stenosis or an aortic atresia. So some reason the blue blood is getting into the descending thoracic aorta to cause differential cyanosis. So here we can say, Jasleen, we can just enumerate this. As you can see in this figure here, that there is no interruption in the aortic arch. This is the physical interruption. So the blood is flowing just to keep the baby alive. So many times you'll come across is a PDA, it has to be closed. No, in this case, the PDA is keeping the baby alive. So a right to left shunting PDA should not be closed also. It needs to be kept open to keep the baby. And this is how you clinically diagnose, that you check the upper limb SpO2 and you document the lower limb SpO2. If you've got two pulse oximeters, you can put it simultaneously and see. You can actually see a difference. Here it is 97 upper limb, 85 lower limb. Some reason the blue blood is getting into the lower limb through the PDA. Whatever the reason may be, that has to be discovered or found out.
So this question is commonly asked in the exam for the students, for the pediatrician, that difference. It's very easy to understand now, I think, with these diagrams, we can understand this part. Let's move to the cases now. So we have 4 cases to discuss if time permits. The case 1, Dr. JK can take this 6 months old child, 7 kg weight. There is a query of history of cyanosis and crying. Mother says, shayad blue hota hai, query cyanosis and crying. And there is no distress on examination. Cyanosis is not surely here. On examination, you find a murmur in left second space. Child is not in CHF, and we get the X-ray. This is the X-ray. What is your understanding of this X-ray now? What do you diagnose based on
case?
This? It's a
Yes,
high
sir.
flow, low flow.
So going through the case, as we've already dealt earlier, first of all, the history. History is cyanosis plus minus. We can say it can be cyanotic or a non-cyanotic. Secondly, there is no distress. With only cyanosis, no distress. That means we are going towards either cyanosis with decreased pulmonary blood flow, or if the cyanosis is occasioned due to any other cause. Then there is history of cyanosis and crying. That is a clue. So in some cyanotic heart disease, because of PS, because of the dynamic component of the infundibular, there is infundibular spasm, which causes increased right to left shunt. So that is giving one clue. Then we go to examination part. There is a murmur, and this murmur is 3/6. So there is a significant murmur also. So a cyanotic child with quiet precordium, with a murmur, not in CHF. Next step is to do an X-ray. When we see the X-ray, clearly this X-ray is of decreased pulmonary blood flow. So there are no pulmonary blood flow, there are no markings on the lateral 1/3. Even in the middle 1/3, the markings are less. Then the shape of the heart. This shape is with upturned apex. This is RV type of apex, the upturned apex. So all the clues are pointing towards one physiology, which is TOF. So a cyanotic heart disease with decreased pulmonary blood flow, with a murmur, with on X-ray also decreased pulmonary blood flow, with RV type of apex. This points towards most probably it is TOF.
So some TOF physiology is the differential diagnosis here. And most likely we're talking about TOF and TOF physiology. So in exams, this is the right way to, as Jasleen explained, talk about CCSD, low pulmonary blood flow, most likely TOF physiology. And based on that, you can go ahead. And the most important one, don't forget, child is not in CHF. So for all the students, it's a very simple case to understand. It's a TOF physiology. And all the spectrum of TOF physiology should come into picture now. Like it can be DRE VSD PS or TOF or pulmonary with VSD. Yeah. So the next, moving to the next part, RR sir, is it possible to miss cyanosis in clinical examination? Like we discussed earlier also, but just to emphasize.
This just to
My
emphasize that it is
cutoff says
highly possible.
80%. Yeah.
Yes.
How?
It's highly possible. Yes, it's highly possible, as we have discussed it earlier, but it's worthwhile reiterating again and again that you can miss it in certain situations. Like there is commonest thing is anemia, Again, I'll go back to it. The patient factors, please don't forget anemia. When the patient is either very dark skin, dark colored, or the patient has put some nail polish on the nail paint, all these things. So these situation patient factors. Then I also mentioned the doctor factors earlier, but it's highly possible. Therefore, as we want to reiterate again, that whenever you have a doubt, please check the SpO2 and use your pulse oximeter. It is easily available. Use a reliable pulse oximeter. So please use it, and you can always do look for differential cyanosis also, an upper limb, lower limb SpO2, and then you can form your diagnosis. Then, of course, the radiograph is giving you the very strong clue: reduced pulmonary flow, boot-shaped heart, likely to be a tetralar failure.
So we move to the next part, MK. Like as we discussed, when we can start medications now. What medications you want to start, and start with the beginning from the first part of this part.
Right. So this slide is like more like a MCQ, and I'll make it like easy. Step by step we'll go. So basically, any one of us know that TOF physiology is a decreased pulmonary blood situation. Okay, right. So diuretics is a strict no, cut, because it's a decreased pulmonary blood flow. So we don't expect diuretics to be given. Strict no. Come to digoxin. Basically, digoxin will increase the contraction of the heart, right? Simple terms. So there is infundibular stenosis, we know, in the case of TOF, and you are giving RV to contract, right? So it will contract against a fixed or a dynamic RVOTO, right? Which will have both the components. So again, that will be something like very haphazard. So again, a strict no for digoxin. Coming to the third point, beta blockers, a very important yes. In the case of decreased pulmonary blood flow situations with cyanosis, so we know that cyanosis is there. So this cyanosis will lead to more formation of, like, blood will be needed. Erythropoietin will be released more. Sorry, in the case, I started talking about iron. So beta blockers basically, they will decrease the infundibular spasm. So it is strict yes. So we do give beta blockers, and it also increases the systemic vascular resistance, which will decrease our right to left shunting. So the beta blockers is to be given in all the patient of TOF, basically. Coming to the fourth, iron supplementation. As I was saying, that it is a case of cyanosis. So more of erythropoietin is released from the kidneys. So for that, iron will be required more. Otherwise, these hemoglobin will be having less iron. So RBCs with less iron. So iron supplements is a must. So beta blockers with iron supplement is a must in the case of TOF physiology patient. A strict no for diuretics and digoxin.
So one more question to the other panelist. I keep seeing in my practice polycythemic patient. They already have hemoglobin of 23. Do you still want to give iron with the 23 hemoglobin, 24 hemoglobin? Ravi sir, you can take this.
Yes. This is again a very common question. We feel they're iron overloaded. Some of you confuse them with thalassaemics because they are also iron with iron. But no, here in this situation, the cells are deprived because of the increased number of cells, the red blood cell mass. That's why the total iron will seem to be high, but each of the red blood cell is deprived of iron. If you see a PBS in a tetralogy of Fallot with a hemoglobin of 23, that will have central pallor. So every patient will have cyanotic heart disease, will have high iron turnover. Therefore, they need to be given iron supplementation. Or what happens is the red blood cells will be deprived of iron, and an anemic RBC is known to be less deformable. So they are very high risk for strokes because the RBCs tend to sludge in the CNS circulation because they're less deformable in the anemic state. And anemia per se increases erythropoietin production, and erythropoietin production is molecularly similar to thrombopoietin, and you have increased number of platelets. So you end up increasing the chances of stroke by not giving iron. So it is criminal to not give iron.
So even with polycythemia, your iron stores are less. So keep replenishing the iron stores with iron supplement. DS, Divyesh, when do you advise surgical repair of TOF? This patient has TOF, 7 kg, 6 months. When do you advise surgical repair of TOF? Divyesh,
So first thing
Divyesh.
first. Yeah.
Yes.
I'm audible, sir?
Yes.
Yeah. So many a times I hear to this question about what is the criteria, at what age, at what weight you can operate TOF. So first thing I would like to break this myth that there is no criteria of weight and age for tetralogy. In many countries, they have started operating TOF in neonatal life also. So it basically comes down to institutional policy, as in India, that which institute is comfortable at what age. Routinely, what we follow here in India is 6 months to 1 year. So less than, at least if you are not following neonatal life, less than 3 months, but by 1 year of age, at least all the TOF should be operated. As the reason mentioned are that more the child grows, more the physical activity will be there, saturations will start dipping down, the CNS complication will start creeping up. So better to operate them in less than 1 year of age group. The weight is not a criteria. And second thing, saturation, they keep on asking, what is the dangerous level of saturation? So in tetralogy of fellow, there is a wide spectrum of patients. Many patients are less symptomatic at 70 saturation also, or many patients are symptomatic at 85 saturation also. So we have to individualize case to case. Whichever patient starts having symptoms on whatever level of saturation, you have to operate those patients. Less than 70 is definitely a bad saturation. You should not keep on piling up those patients. But whenever the patient is reaching 6 months of age group, saturation is starting to drop, you operate those patients.
So to summarize, yes, put a very important point that no cyanotic patient should go beyond first year of life for sure. And second thing, most of the children will need surgery between 5 to 6 months of age. That is the point here. And we're not talking about weight nowadays. So anything to be added by other panelists, Murtaza and Dr. Ravi sir? Anything we have missed here?
Yes. Basically, it is like even in the guidelines, it's mentioned center to center. You go to America, they're operating newborns with TOF because the babies are larger and they've got the expertise to handle in the post-op. In India, we have a research limited setting. So therefore, we use this arbitrary thing as one year. But you have a patient who can afford his surgery, can go to the best centers in the country, and the centers are also well equipped. Then there's no harm in getting the baby operated earlier also. So it's a case to case and symptom to symptom based. So this is one lesion where the recommendations also say it is little flexible. So upper limit we keep as 1 year. Lower limit as much other center can take.
So most of units in Delhi, most of units are operating at 4 kgs. They will operate at 4 kg complete repair in Delhi most of the times. So let's move to these are the guidelines which you can go through. One was the Indian guidelines, exhaustive guidelines for every disease, and this is STG by IAP. Last, I think, published in 2022. You can go. Both of the guidelines are simpler, and you can go through these guidelines. For all the students, this is mandatory to go through the guidelines. Now let's come to the case 2. It's a 4-year-old child, recurrent LRTI, failure to thrive, and on examination there is a murmur, murmur 2/6, and query white fixed S2 split. RR sir, this child is 4-year-old with some murmur. How do you want to go about it?
So this child, since we're discussing cyanotics, so take it that this child is a cyanotic child. We always have a recurrent LRTI with failure to thrive, high QP. Child may not be cynosed, but we check SpO2. As a good pediatrician, I will always check for SpO2 and decide whether it's a cyanotic heart disease with increased QP or acynotic heart with increased QP. Then on examination, white fixed S2 split indicates only one thing, that is a presence of a non-restrictive atrial septal defect. So a cyanotic with ASD, we should always think of only one diagnosis, that is TAPVC, a totally anomalous pulmonary venous return. If it's an acyanotic with a white fixed split, we'll just give a diagnosis of ASD. So this is a cyanotic, increased pulmonary flow, failure, CCF, congestive cardiac failure, failure to thrive, and white fixed S2. So we think of TAPVC. Again, I'll take an ECG and an X-ray. So let us see what the X-ray says.
To differentiate here, do you want to do pulse oximetry to differentiate? Because a 4-year-old child, TAPVC, do you think child can have TAPVC at 4 years of age?
Yes, sir, it can happen. It's not very common because most of the times we associate TAPVC with very sick baby, a newborn. So these are those babies who have obstructed TAPVCs. So wherever the pulmonary veins, the abnormal pulmonary vein which is going is getting obstructed. But a small subset of patients, they tend to not have obstruction and they have a non-restrictive ASD. So these are those babies, children who tend to survive well. They have just a little, as I said, these are the ones in India, especially we are a resource poor country. So these parents who barely can afford to even get a medical checkup will say, okay, he's a little slow, he's a little lethargic, let him be. Till one fine day they realize that he's too sick. So they come to us very late. But if the child has got good medical care, these are the ones who would have been picked up much earlier. So these are actually the neglected TAPVCs who have survived. That's all. It's their destiny that they are alive and they have come to us.
So
So they're very few,
90% of,
but can happen.
sorry, Dr. Ravi,
Sir.
90%
Yes.
of cyanotics will die in first year, but
They
10% of cyanotics will live by adolescent or older age group. I'm sure all of us have seen 30-year-old TAPC, 20-year-old of anything. There's no limit in India. I've seen 70 years, anything we have seen here. So we understand this part. The age is not the criteria to define cyanotic age cyanotic. That's why I want to say to the PGs, don't go by the age that this 10-year-old child can't have TAPC. That's a misnomer. That's a misunderstanding. TOF, TGA, anything is possible. Anything is possible, even in older age groups. So, other panelists, what is the oldest TOF you have seen in your practice? All four panelists. Oldest TOF.
I have seen a 72-year-old TOF.
72-year-old.
Yeah, and
Someone has to beat this.
was operated.
No, 72.
Was operated at NH during our fellowship days. So we were banging our head. Why was she operated at 72 years old?
Yeah. So I've seen 45-year-old TAPC,
Yes.
20-year-old Alkapa. I've seen
Yes.
20-year-old Alkapa. So all of us have seen this cyanotics
Adult
beyond their
CHDs.
limits. Yeah.
Yes.
So during fellowship, we had this always misnomer whether it is operable or not. When we see large VSD, large PDA, whether it is it has gone beyond the age of operability. So we asked our ma'am, Sejal ma'am was there. So we asked her, ma'am, 72-year-old, is she operable? And then she told that TOF, there is no limit of
No
operability.
Yeah,
I don't think anyone can beat Dr. Divyesh in the case of top 22.
No.
Quality of
I
life
am
will
much
improve,
lesser, 30 years.
Quality of life for 10 years will improve.
Yes, exactly.
Yes.
And ma'am told the same thing, that she will live good 10 years afterwards.
Yeah. So this is the X-ray, MK sir.
Yeah.
This is the X-ray of the last patient, 4-year-old child,
Right.
with high flow, possible high flow.
Right.
Yes.
So already
And the-
Dr. Ravi sir has dissected the case very well, and he has given us two differentials of either it is a cyanotic or a acynotic. In cyanotic, he talked about TAPVC versus with a scenario, and acynotic with ASD.
Yes.
Now, if we see this X-ray, it looks more like an increased pulmonary blood situation or something like pulmonary like plethora, right? So, and if we see the borders of the heart, if you can see that this part of the heart is making something like 8. So it's more going towards like the classical TAPVC, which we were talking about. Mind it, this is not a neonate. In neonates, we don't get it. This is something like snowman or a figure of it. And this figure, the different parts have different like the reasons. So if you see, if I cannot mark it highlighted, so this is the part, the lower part of the...
I will do it for you. Just start.
Right.
Yeah.
So the lower part of the heart on the left side, left border, is due to the dilated right ventricle. Okay. Above it is the vertical vein, which is going up. Okay. Then we have the innominate vein, which is showing the horizontal part. Coming down is the dilated SVC. And then is the dilated RA. So this is completing our complete figure of it, the classical TOF, which is seen beyond 6 months of age, basically. So we have now made our diagnosis towards, so saturation in this will guide us very well. So he is expected to be saturating not very less, in the range of around 85 to 80. I'm not expecting it will be deeply cyanosed because this is an admixture lesion. So this is the way the things are like guiding us.
So in the chat box, Dr. Ahmed has said figure of 8, rightly said. Thank you, Dr. Ahmed, for answering this. And Dr. Nehal has asked one question. What about TOF with MAPCA in terms of operability? When in the last case, we are talking about operability, like any age is operable. So what about TOF with MAPCA and operability? Anyone wants to take this comment?
Yes, one thing you'd like to deal with it now also. And of course, in one, we are going to discuss a little bit more about these high pulmonary blood flows operability. So we can discuss this there also, sir. So I think, shall we club it there and discuss together, the MAPCA also?
I think we'd cover TOF here right now. With TOF with MAPCA, we cover here.
No, TOF MAPCA is one scenario that major aortopulmonary collaterals. These are the ones can have 2-3 scenarios. One, it may still be a low pulmonary flow because the MAPCAs are very small, they're stenosed, and they're going on reducing in size. There may be another scenario when you have a pulmonary atresia with very large MAPCAs. So these sometimes behave like a high pulmonary blood flow situation. These children present with high pulmonary blood flow, CCF, they may not be very cyanosed. They may need diuresis also sometimes, very rarely. And many of them are diagnosed in the second decade. There are some patients we have diagnosed with infertility treatment. They're not been able to get pregnant. And these ladies, when they went for some procedure, laparoscopy or something, they found SpO2 in the range of 85 to 90. So these patients
Dr. Ravi,
would...
sorry, I will interrupt you, Dr.
Sir.
Ravi.
Sir.
You know, in my experience, we are clubbing these two disorders, TOF and
Pulmonary
palmatrisia. I
atresia.
think they are, I
Okay.
keep them separate actually. Normally, I keep them separate.
Yes, they're separate. They're separate.
Palmatrisia, VSD, and MAPCA, as you are saying, rightly saying, large MAPCAs are seen in this group. But TOF with large MAPCAs, which is PS
Okay,
patient,
okay. Sorry.
they
When
are
it's coming to TOF, then their MAPCAs, they just treat like TOF. The
yeah,
presence or
mostly,
absence of MAPCA in TOF will not
Yes.
decide the operability. So
And
they
we
have to
can
treat it
cat
like
before
less
it.
common.
Huh.
So we might have seen one or two cases with large MAPCAs causing inoperability. Rarely, like I'm sure you must have seen also one or two cases of inoperable TOF with MAPCAs, but they are rare, extremely rare.
very rare.
Mostly
Very
we're
rare.
talking about this group, mostly. But in pediatric practice, TOF with pulmonary and TOF are clubbed together, which is a common understanding. So we can club them also. In essentiality, as my experience says, pulmonary may become inoperable. TOF with MAPCA, maybe 1 in
Makes
1,000 cases.
very rare.
Yeah,
Very rare.
may have.
Yes.
Now,
And we have to close those MAPCAs before surgery so that they don't bleed afterwards.
Yeah.
So cath has to be done.
So this one is covered. Now, MK sir has taken again this. So this
Yeah.
patient was found to have supracardiac TAPVC and mild PH. It was a
Right.
4-year-old child. So
Yeah.
what do you plan about management? Again, drugs.
Yeah. If like,
One by
first of all, like if I have to give drugs, out of these drugs only I'll give diuretics, because we can see that there is pulmonary congestion. Basically, it's a venous congestion. So diuretics is the only drug which is to be given in this case. I'll say something about sildenafil, which we have seen in our lots of pediatric practice. Sildenafil is something which basically increases our cyclic GMP, and it decreases our PA pressures. So if the PA pressures are decreased, we'll have more of blood flowing into the lungs. You can see the X-ray, it was already congested, right? And if you are giving more of increased QP situation, it will be deteriorating it. So never in these cases for PAH treatment, don't give sildenafil. In these cases, diuretics are the first thing, and then he's already 4 years. Talk to your surgeon and send him to OT. That's it. It's not obstructed TAPC. It will be an elective thing, right? But he's already 4 years, the right time to operate him. Other drugs are of no use in this, digoxin or the beta blockers. So the only thing which you can give here is the diuretics, which is there. And one more thing about sildenafil, in the case of even shunt lesions, when we have a shunt lesion which is large enough, moderate to large, again sildenafil, that is a hyperkinetic pH situation. Again, sildenafil is not to be given to decrease the PA pressures, because it will again increase your pulmonary blood pressure, which will deteriorate the condition. So not in those conditions also.
you know, there is one comment by Dr. Baldev sir about obstructed TAPC. He has said obstructed TAPC known to present with RDS and ground glass opacity on chest in newborn,
Right.
commonly treated as HMD and sufficient given. And such
Right.
babies think of TAP. So the rightly said, sir, obstructed TAPC in newborns and even in 1 month or 2 month old child can present. They present like RDS with a HMD like picture, and we treat them with surfactant. And in our practice, I say, if a full-time child, you are giving surfactant, think of obscenity. So that is the point is well taken. Anything else you want to comment on, Murtaza, about this obscenity APVC, as we have discussed?
So obstructed TAPVC, whenever we are getting, as we hear about it, only thing which we have to remember, it's a surgical emergency. As soon as you see a obstructed TAPVC, call your surgeon, ask him to come in the night and operate it, because obstructed TAPVC is a surgical emergency. It will lead to bad pulmonary venous congestion, basically.
Ravi sir, your
Not
experience about obstructed TAPVC, like identifying when they, like the most important point is to identify this patient.
Yes.
How do
High index
how
of
to reach to the
suspicion.
obstructed TAPVC? Yeah.
Yes, high index of suspicion that any baby can have TAPVC. Firstly, if a fetal echo has been done, well and good. If not, also that should not be an indication. That should not be a guide to form your diagnosis, because the X-ray suggestive of RDS. If the X-ray baby is very sick, acidotic, then take it for that. It's a 50-50 chance of the baby having a obstructed TAPVC. So this is one situation where an echo would be an emergency followed by surgery as an emergency. So this is one place where you have to actually ring all bells, call your whatever 911. I'll say, as they say in PALS, you call your 911. The 911 of cardiology has to be activated here. This is one situation.
Yes. So in our unit, what we do is like we tell our fellows, if his PH, newborn PH, PPHN being managed and is not responding to your routine therapy, then you think of TAPVC. HMD patient in full-term child, think of early TAPVC, absolute TAPVC. These two things you should not miss. Severe PH, not responding, think of absolute TAPVC, and full-term with HMD, think of absolute TAPVC. Yeah, now we go to the case 3.
I would
Yeah,
like to add here that
Divyesh.
yeah,
Sorry.
many times when we get newborns in obstructed TAPVC and there is some history of meconium or RDS and we get just biased with that history. So it has happened many times in our ICUs that patient has come from periphery with the history of meconium. They keep on managing there. Then the patient comes here in NICU. They start management of PPHN. They continue the management for 48 hours. And after that, they get the idea that there is something which is not going according to the plan.
So early. You want to say early.
Don't get
Early.
biased by the history.
Yes.
If the meconium history is there, any other history is there, but if, as sir told, that it is not going according to the plan, patient is not behaving as per routine PPHN, get an echo done. Get a high suspicion of TAPVC every time the patient is not managing saturation.
So Divyesh, obsolete TAPVC, what is the outcome nowadays? Obsolete TAPVC newborn. What is the outcome here nowadays in India?
I would say if managed properly and good ICU care is available, the outcome is excellent. We have hardly lost a baby of TAPVC in last 3 to 5 years when we have started operating newborns in our centers. We have not lost any baby of obstructed TAPVC.
Yeah, so excellent outcome nowadays. Only thing which I believe is if the child has got sepsis,
infection.
Then
associated factors.
then we are in trouble. So we find sepsis as a major comorbid factor and mortality factor.
I'll just add
Murtaza.
for our intensivists, because now Neeraj sir is a provocative of like focus. He teaches everyone focus. So like this is a very important in intensive care when you are in the NICU and you have the echo machine. If you are not able, it's most likely that you won't be able to see for the pulmonary veins. Just see for the direction of the PFO. If the direction of PFO you think is not left to right, it is either fully right to left or bidirectional, there is something garbage. The pH is severe or all the pulmonary veins are not draining into that side, right? It means it is draining on the other side, the right side. So you should suspect TAPVC in those cases also. So always look for at least the direction of PFO flow, right?
So as you rightly said, I've been training focus program, but PFO shunt direction to explain and to teach needs lot of commitment from the fellows. They have to keep doing it. But PFO shunt direction is difficult to pick up for the beginners, but it can be learned. It can be not impossible, but it's difficult to pick up. Divyesh, you want to say something about this?
I tell my fellows to see left atrial border. It is very easy to see, very easy to pick up. So whenever you see fourth chamber overpowering right side of the heart, then you just focus on the left side. If you are not able to see, zoom the left atrial border. If you are not able to see punctuations, then get the suspicion. After that, all these things will come in mind.
Yeah, bald LA. It's called bald LA.
Yeah, bald LA.
Yeah. Okay. So we move on now. Case 3. So Jasleen will take this case. Full-term newborn, discharged on day 3 of life on breastfeeds and went home with new clothes. Now presents to emergency room with cyanosis on day 3rd, and in the emergency, SATs are 60%. What do you think about here, DD?
So a full-term newborn doing well, discharged, and then suddenly comes to emergency with a low saturation. So there was something which was protecting the baby till day 3 of life, now which is not there. So that thing is PDA. So PDA, which usually closes by 40 to 72 hours, that has closed, which is leading to severe cyanosis. So what does this mean? That means the child is dependent on that PDA. which is known as duct-dependent pulmonary circulation. So we have two types of circulation, duct-dependent systemic circulation and duct-dependent pulmonary circulation. So a systemic circulation duct-dependent will present with shock because the left side, all the outflow is obstructed and that is dependent on duct. But a duct-dependent pulmonary circulation will present with severe cyanosis. So that baby will have severe cyanosis if the baby is totally dependent on duct. So what all DTs do we have for this? What all do we consider when we have duct-dependent pulmonary circulation? The most common is pulmonary atresia with intact ventricular septum or VSD. Like any case of pulmonary atresia which was dependent on duct, that duct has closed, now leading to cyanosis, most common. Secondly, critical PS, which was also having some flow through PDA, that is closed, presenting with severe cyanosis, or TJ with intact septum, in which PFO is also needed, that ASG is also needed for mixing, but PDS is closed. So that can also present with severe cyanosis. Then also we have one category, which is functional pulmonary atresia. So what is this functional pulmonary atresia? That means pulmonary valve is present, but forward flow is not there. The blood is not going through the pulmonary artery, but the valve is present. So this could be in cases like Epstein's anomaly, in which all the blood which is coming to RV is going back to right atrium due to severe TR. So there is no forward flow which is going to this. So Epstein's anomaly is one case. Or if there is severe RV dysfunction, RV is not able to pump blood forward. That can also lead to functional pulmonary atresia. Or if there is severe PPHN, the pulmonary artery is not getting any blood. So all these can also lead to functional pulmonary atresia. But for all cases, whenever we find that the baby is having duct-dependent pulmonary circulation, the most common diagnosis is pulmonary atresia. So that is an emergency. We have to give something which opens the duct, and that is Prostin. Here comes the roles of Prostin. Even without echo also, we can start Prostin if we are suspecting that this is the typical history. The baby was doing well and suddenly deteriorates. Then we can start
Divyesh,
without even
could we have prevented this catastrophe? Could we have prevented this catastrophe? Patient presenting on day 3 and with
yes.
50%.
So
Divyesh,
here comes the role of neonatal screening.
SpO2 screening, yes.
Yes, what we discussed earlier. Here comes the role of neonatal screening, that every newborn has to be screened with saturation before discharge.
So Ravi sir, Divyesh sir, can we miss on pulse oximetry also? Is it possible to miss on pulse oximetry? Suppose my
Yes, it's possible, sir.
Can I miss
Yes,
it?
sir.
Can I still miss it? I did
Yes.
the
Yes,
pulse
it is possible.
oximetry. I did all the steps. Still, it's possible to miss the disease.
Yes, if there's a ASD
Yes,
is
sir.
large in a TGA, suppose the ASD is large and the PDA is large. So it's a good flow taking place. So baby doesn't have symptom, then SpO2s will be wavering somewhere around 93, 90. But that moment when you're checking, probably it has just gone up because some reason the baby is like very happy and thriving. It can happen very rarely, but the percentage of missing such babies reduces. So out of 10 babies you will miss in a year, you'll probably miss only one baby in a year. So that's why it's important to do this, sir.
You start developing practice of taking saturation in all babies. If you make it your protocol that all the babies at the birth and when gets discharged on day 2, if you are taking the saturation, then you will, as Ravi sir told, you will have very less chances to miss this kind of babies.
Because sometimes even pulmonary is a large VSG, a large PDA. SATs may go above 95. So sometimes you will miss because you're not doing the invasive PO2 measurement here. You're doing the pulse oximetry. Sometimes we do miss these cases. Even at 48 hours, SATs may be 95% because we are not doing the invasive ABG monitoring here. PO2 will not go up, like the old concept of hyperoxia test. But here, most of the times, like 99% of you are right, that will not miss it. So what I'm saying is, even if you have done the screening, the SATs were okay, you don't think that you can't miss. And day 3 child, you still start the prostaglandin here. Now, in what disease you would not like to start prostin? What is the harm? Suppose this child doesn't have a drug-dependent circulation. I start the prostin. What can go wrong here? What is the disease which will worsen with PGU? Is it possible to worsen the disease?
Only one disease comes in my mind is obstructed TAPVC.
Yes. So obstructed TAPVC, but again,
but still, it won't kill the baby, sir.
It won't kill the baby.
It won't kill the baby. And also X-ray will help you.
Yes.
So if I come to the X-ray here, the TAPVC obstructed will be white lungs. So if the lungs are white in such cases, don't start prostate. If the lungs are black, it can't be
Have to
oxidative.
start.
So if the X-ray is available, in this case, X-ray like black lungs, then surely you can start prostate without a fear of causing trouble to the child. Or you start the prostate, get the X-ray done meanwhile, and if the lungs are black, you are sure that I'm on the right. So this is the RRSA duct-dependent pulmonary flow DD. What do you want to say about this differential diagnosis again? Just to
Again,
highlight.
duct-dependent pulmonary flow, as Dr. Jasleen has pointed out, it can be a systemic circulation dependent on the duct, in case interrupted arch, severe coarctation, or it can be a pulmonary circulation dependent on the duct, like pulmonary atresia, intact IVS, critical PS. These are the situations. These are life-threatening emergencies. So without waiting for an echo, please start a PG1. And these babies, most of the times, we need to be transported to a tertiary cardiothoracic surgical center, which are very few in our country. You have to remember, we can count on our two hands the number of good pediatric cardiothoracic surgical centers in our country. We can still count on our hands. That's so far and few. So they'll need transport. So a transport is possible only with PG1. And when you start PG1, please continue PG1 as an infusion. It's not to be given and stopped, because you stop it, it's a very short acting drug, few seconds. The moment you stop it, the duct will close again and the baby will die en route. So please don't do that. PG1 to be started in duct-dependent pulmonary circulations is life-saving, life-saving, life-saving.
So you want to start with VSD also? Pulmonary with VSD will also need prostaglandin, or like VSD will allow the mixing, something like this. There is a confusion about among the students that one is pulmonary without VSD, one is pulmonary with VSD. Both will need prostin.
The lungs need
Yes.
prostin.
Lungs
Remember
need
that.
prostin. Yeah.
Not the ventricles. The ventricles don't need prostin. The ventricles are full of blood. But then whatever amount of blood is present in the ventricles, if they're not reaching the lungs, the baby will die. So only way it can reach the lungs is when there is a connection between the systemic and the pulmonary circulation. That is nothing but a PDA. And if the PDA is close, to a BT shunt. That is done surgically. Surgically, BT shunt is nothing but an artificial PDA that's created. So to be given in pulmonary atresia with VSD.
Suppose I have started prostin. Suppose I have started prostin, and for how long I should take time to decide whether the prostin is working or not? Like any answer for that, Divyesh or Ravi sir, whatever.
So when you start prostin, what we usually practice is you start with a dose like 0.5 microgram per kg per minute. If you are not getting the result in 0.05, then you increase the dose to 0.1. So up to 0.4 microgram per kg per minute, you can increase the dose. Once you start getting a saturation, then you start titrating again, and you keep on a maintenance dose like 0.025 or 0.05 microgram per kg per minute. So this is the way you routinely practice here. We start with 0.1, then we increase, and then once you have confirmed that the duct is open, saturations are behaving nicely, then you keep on coming down the dose of prostaglandin.
So the idea is we don't wait. It's a continuous, like your inotropes. It is a real time thing. You have to sit there in front of the baby and keep doing it. You can't say a start, I'll come back after half an hour. No. It is to be real time, to be titrated up and down based on your saturation. Still you reach your target saturation and maintenance levels.
Yeah, or coming
Also
to the same thing as the inotrope sir has said. Dose of prostin will also depend on as an inotrope. Like suppose child is in shock, BP is 20 systolic. You start on higher dose of adrenaline.
Yeah.
Similarly here,
That's what,
the stats are 50%.
You
Maybe
start
I will
with
go
higher
on the
dose.
higher
always
dose.
start with higher dose first. Yes.
Then no,
Then
not
taper
always.
down.
Not always. If the stats are
With the
like
situation we have given.
Yeah.
if the BP is 90, I will start at 10 mics. If the BP is 20, I will start with 20 mics. Similarly here, range can be done. So like if my sats are 60, 50, I will start on the higher dose of 0.2, 0.3. But if our sats are 80%, I may start on 0.02. And also, Divyesh, what do you think about days of life? Suppose the child presents on day 10 or day 3 or day 2. Does your dose vary? Your starting dose. Like child is presenting on day 1 of life with SATs of 80% versus child presenting on day 10 of life with SATs of 80%. Like, do you change the dose in such scenarios? Or do you
We have not done it. We have not done it according to the age. But we as you told, sir, we do it based on saturation only. The saturations are low, you can go straight away with higher dose. Saturations are in moderate range, you can start with moderate dose.
Yeah, like an inotrope, like an inotrope. So
Yeah.
I think also I will follow same dose, but in my practice, I say it's my personal practice, not the guidelines. Older the child, lesser chance of response to the prostate. So in the older child, we tend to give on the higher side most of the time, not always. This is my personal experience, not guidelines.
It must correlate with the physiology
So this
because
was
the older child
yeah.
anatomic closure of the PDA must have started happening. So you start
Especially
with higher.
term babies, especially they are less responsive. So rightly, as I also agree with Neeraj sir, and if I get an older baby, I'll just go start high, come down. So that's the dictum which I also follow.
Yeah. So now, let's last case. Time we already crossed time 10:30. We'll
Sir,
finish this case.
continue. This is the last case. Please continue.
Okay. Admixture lesions. So we're trying to cover the last group. Apparently, happy baby with mild cyanosis and hyperdynamic chest, mild tachypnea. I don't know if I should say hyperdynamic chest or mild tachypnea and SATs of 80%. MK sir.
Yeah. So let's decipher the case again stepwise. So this is apparently happy child, asymptomatic with mild cyanosis. So it goes something, and we have a hyperdynamic chest on examination. Tachypnea is there. SATs is 80%. So this is clear cut, a cyanotic congenital heart disease. SATs are 80%. And it is like increased pulmonary blood flow. We can see that. We can see the X-ray very clearly. There is pulmonary plethora very clearly. It's reaching up to the lateral 1/3 as we have talked about. So this is a case of increased pulmonary blood flow, cyanotic congenital heart disease. We have two lesions in this, right? We had admixture lesions or a transposition physiology. So this is the way we are like heading in this case, basically.
Yes. And what about upper part of mediastinum? What about this part? Any clues here? Like narrow mediastinum, wide mediastinum, something like
Okay.
this?
So
Murtaza
yeah.
sir?
So in addition to that, we'll see that like if we see that the upper part of the mediastinum looks like more like sting, like narrow, and the lower part is classical like egg on side jo bolte hain hum. Okay, it looks like narrow mediastinum with egg. Why is it narrow? Because if you think of like this is basically heading towards a TGA. Okay, so the great arteries are like anteroposterior, more like anteroposterior, the aorta and the PA. So the upper part of the mediastinum becomes narrow, and this becomes like sting on the egg-like appearance.
Yes.
So it's going
Yes.
towards TGA physiology, more
So
towards it.
mostly I rely on somehow my practice is rely on the narrow mediastinum more. Figure of agon side I have never been able to confirm my practice, but this narrow mediastinum I heavily rely. So because thymus shadow
Correct.
is not seen, and that is a very
Correct.
prominent sign. My understanding that this is very classical sign. Narrow mediastinum gives more confidence to call it TGA than the agon side. But other panelists can also contribute to the X-ray assessment.
Yeah.
What do you think about the X-ray? Ravi sir and Divyesh and Jasleen.
Again, here, if you look at the ventricles, one is the upper part, then lower part. It's something like a LV apex as well as an RV. It's somewhere in between because it is also enlarged laterally, but it's also lifted up. So you have to take into account that you've got a biventricular enlargement which has taken place here with some RV dominance also on this case. So with this situation, again, it goes into some kind of situation where your RV is also volume and pressure overloaded. So that also gives you a clue towards the diagnosis.
Divyesh?
Yes, pulmonary plethora is evident, so you are dealing with increased QP kind of situation. And as you told, I also give more emphasis on narrow mediastinum rather than agon side because it has happened many times with me, like commentators curse that you tell, yeah, it पक्का agon side लग रहा है, लेकिन it doesn't turn out to be TGA. और जिसमें नहीं लगता है उसमें TGA निकलता है. So narrow mediastinum definitely gives you more help rather than going for typical. Yeah. In snowman's heart, figure of 8, in older children, it is very much diagnostic. But in newborns, you will not get a classical agon side most of the times.
Yes. So this can be a TAPVC also, but TAPVC normally would not have narrow mediastinum.
Narrow mediastinum, yes.
Correct.
So with increased pulmonary blood flow and narrow mediastinum, we have lowered down to most TGA. Because with increased pulmonary blood flow, pulmonary bay should be evident. Because that is increased due to increased pulmonary blood flow. The pulmonary artery should be highlighted. Here, pulmonary artery is not seen because it is behind aorta. So increased pulmonary blood flow with narrow pedicle, we should think more of TGA. This should be takeaway, I think.
DS, Divyesh, management of drug-dependent circulation. Like you want to start PGE1 here empirically without echo or with echo. This thing I think we covered. You can cover this
Yeah,
question.
we have covered, sir.
Yeah.
PG1 is mostly diagnostic as well as therapeutic. You start PG1, saturations are increasing. You have made the diagnosis without echo. So PG1, there is no dilemma. You should not wait. You're getting the patient. Patient is not improving. You can start PG1. How many days to continue? This question I routinely get from neonatologist. कि सर इसको कितने दिन तक PG1 के साथ रख सकते हैं? So PG1 is a bridge therapy. It is not like you start PG1 and you keep the patient कि वो न्यूबॉर्न से इन्फेंटाइल एज में चला गया उसके बाद आप ऑपरेट करोगे, ऐसा नहीं होने वाला है.
School भेज देंगे.
PG1 is a bridge therapy. It is for your ICU care to a cardiothoracic tertiary center. You have to shift the baby, so you start PG1 for till that period of time. Or otherwise, patient is having some associated factors like sepsis है, उसके साथ आप डील कर रहे हो, तो उतना टाइम आपको बाय करना है. You have to buy
So till surgery. So till surgery happens.
Till surgery, you have to buy the time. So for few days, I would say 2 or 3 days, you can at the most keep PG1 going on, because PG1 also has its side effects. Patient will go into apnea, patient will start having bradycardia. If you keep on prolonging PG1, duct will become fragile and intra-op you will start getting troubles. So PG1 is a bridge therapy. It is, you have to keep it in mind. ये bridge therapy उसके ज़्यादा कोई role नहीं है उसका.
Can we stop it after doctor's opens? Like doctor is open, I stop the patient and then send to surgery.
We have discussed. Dr. Ravi told that वो short acting drug है. आपने चालू किया, बंद किया, वापस डक भी बंद हो जाएगा. So you have to keep a minimum maintenance dose, and with that maintenance dose, patient will go into the operating room.
And if you're shifting to a distance center, apnea is a high risk factor here. So do you want to intubate this child before shifting, or it's okay that you are okay? Like there is a controversial question. This is a controversial question.
I think it will based on policy of institutes and policy of the NICU. If you're sending the patient with a skillful person, then there is no need of intubation electively. You can send with all the prerequisites, and if need arises, you can intubate on the way also. If you are sending with a person who is not equipped with intubation, you can well in advance intubate the patient and send to the cardiothoracic center.
Yeah. Because after intubation, you're committed and you are prone towards sepsis, early surgery. So you are committed actually then. You're in trouble.
Nowadays, even we are starting caffeine for these patients to prevent like apneic episodes.
So yeah, there are few guidelines. Some people have started. Yeah. So for the students, caffeine to prevent apnea. Yeah. So this is the almost the last question now. Prognosis in CCHD. Like we think these children may not do well. What is the opinion of the panelists? Here we go one by one. Cyanotic CSD need to be operated timely. Like we have discussed possibly, what is the best time to operate a cyanotic CSD? Is there any weight criteria? Is there any age criteria? What is the best time to operate cyanotic CSD?
Best time is now. That's what I can say, that especially high QP cyanotic CHDs have to be operated now, because they also can Eisenmenger, which we don't usually, we call it, technically we don't call it Eisenmenger, but they become inoperable much faster. A TGA VSD, you leave him for 2 months, will be inoperable after 2 months. You have a TAPVC, PAPVC may not survive at all. With that obstructed TPVC may die. So a high QP CHD, cyanotic CHD to be operated now, it's an emergency. As early as possible. TOFs, 1 year. Maximum 1 year. That's what a take-home message for that would be, that high QP is a much more serious thing than a low QP when it comes to operability.
Yes. And outcomes in current era. Murtaza, what do you think about outcomes in India?
So overall, if we see the last 15 years has been a boon in the pediatric cardiology outcomes in our country. We have now numbers of centers which are doing high-end surgeries and almost all the surgeries and interventions. So in the present scenario, I should say that more than 95% of these patients need a single intervention or a surgery. Only 5% of them are needing recurrent surgeries. And overall, the mortality has decreased to less than 2%. If we say this is not the one-time mortality, like overall throughout the life due to this congenital heart disease. So outcome is like something like near excellent, what I should put in one word.
So, Jasleen, mortality and morbidity. What are
Yes,
the
sir.
factors that are deciding the prognosis in terms of mortality and morbidity in CCHT? Like what we can
Just
do to change the mortality and morbidity, especially from the pediatric perspective, from the peds cardio
treat
perspective.
early, diagnose, suspect early, and send for surgery early. That is the one major factor which we can prevent the mortality and morbidity. Since in case of TOF also, some patients, they go on to adult TOF. They are like adolescent TOFs. They have all the complications related to TOF, like polycythemia, they'll have higher blood counts and cerebral abscesses. Stroke can also occur. Then liver damage can occur in single ventricles, that AKI. So everything will happen. That will the morbidity will increase if they are not routinely, timely taken for surgeries. So always suspect early and then refer for surgeries.
So, Divyesh, what is your opinion about needing of multi-stage? Some part has been covered. What disorders will need multi-stage surgical repair in CCHD group?
I think multi-stage repair has limited to single ventricle physiologies more or less now. Apart from that, as we were seeing in history that tetralogy required multi-stage, it has been obsolete now. Most of the TOFs go for single ventricle repair. So I think multi-stage repair is restricted to single ventricle physiologies where you do PA bending or BT shunt or ductal stenting in first stage. Second stage would be bidirectional gland shunt, and later on completion Fontan.
Okay. And what about the quality of life? Like, do they play cricket? Can they do everything in life? Like, quality of life is compromised in cyanotic CSD patients who are post-operative?
No, not at all. Not at all.
They lead
Okay.
absolutely normal lives. You have to remember that we are giving them, it's like giving them a normal life. That's the important part of it.
Yeah, yeah.
I,
So,
according to me, according to me, to see the joy in parents' eyes after they have seen all their life their baby cyanotic, and suddenly they come out of the operation theater, and many times happens that relatives say, "Sir, situation abhi to 100 hai raha hai." So it is like magic to them. And
yes.
after that, when they see that child is behaving nicely, it is not having spells, not having any other problems. Weight also, many times we see that tetralogy won't have problems of somatic growth. But I have seen that you operate the tetralogy patients and growth also gets improved
So,
very nicely.
see, Divyesh, chronic cyanosis will always hamper the growth. It's not possible.
Mhm.
Chronic cyanosis, like if you continue to have cyanosis for years, you will have stunting, you will have
Yeah,
less
stunting
weight.
is very common, but as what I'm telling is in you operate TOF mostly in 6 months to 1 year.
Yeah,
So in compared to that high shunt lesions,
yeah,
TOF will not have that much problem of weight
yes,
gain.
true. That is totally true. But in
Yeah,
older age group, you see the other
yeah.
comorbidities. Yes. So we come to the point that they have good outcomes nowadays. Morbidity and mortality can be reduced if referred on time. Quality of life can be excellent with good neurological outcomes. If they come on time, we should have the patient without cerebral abscess, sepsis. So early referral should improve the outcomes. So to conclude our session today, pulse oximetry, as we highlighted again, is important. Top physiology, don't give diuretics, please. High flow, give diuretics and early surgery because they become early Eisenmenger here, as we have discussed earlier. Truncus, TAPVC, TGA, VSD, they should be operated as early as possible. Drug dependent circulation, PG1 can be started empirically also. And black lungs on X-ray can give you confidence to start a PG1. So any other question we can take from the audience? Otherwise, we can keep this session closed. Thank you. Chairpersons,
So thank you
yeah.
so
Very good.
much. Actually, all the questions, most of them has been taken care during the discussions only. And many a times, even Baldev sir has replied. One question was that they asked for the pulse oximetry, which technique or which machines are good. So in that, I replied about Massimo and Nelcor, but any other physiology or machine you people know, please
I
All
think
comment
right
on it.
standard
now
pulse
motions,
oximetry. Yeah.
yeah, Massimo has to be taken as the best machine for now. It has motion sensors, so it has been done well actually. Slightly costlier, but best.
Yeah. So thank you so much. Baldev sir is also here, and he many a times he always liked the PG teaching, so he's commenting at many of the topics for the PGs to take note about that particular thing. Thank you so much, sir.
Baldev sir is
Baldev sir
excellent
is a
and
teacher to pediatric cardiologist
life
also.
of pediatrics in Gujarat. Baldev sir is life of pediatrics in Gujarat.
Yes.
Sir is teacher of pediatric cardiologist also.
Sorry.
Almost. Yes. And
Actually, I
Baldev
learned
sir,
a
any
lot
comments
today.
from you, sir? Comments from Baldev sir.
Sir is here.
Actually,
Yes, sir,
I was listening to all of you, and really I was happy to know that all the 5 pediatric cardiologists, they were first focusing over the history, then examination, then deriving some information, looking at the X-ray. In X-ray also, I will say very good points pertaining to the general pediatrician, and then drawing some conclusion and last echo. Otherwise, in modern era, we know that this is the biggest problem. I'm really very sorry. But somehow, really in today's discussion, it was impressive. And really, I learned a lot from the discussion that even being the general pediatrician, how you can contribute. And I think this is very important for every pediatrician to know the basics. As already you discussed, that simply if you remember that before the baby is discharged, probably may not be in first 24 hours, but after 72 hours, if you measure the SpO2, and I think nowadays it is routine that not just, I will say, measurement, it should be documented on the discharge card. Because many a times it may create the problem because later on this cyanotic CST detected, parents may come back and may sometimes be uneducated or having some really information, they may create the issue for this practice. So I think it's not only for our academics, but even for legal and from this issue, practice point of view also, these points are very, very important. And to be very frank, I learned a lot. I remember Dr. Raj Tandon sir from AIMS. In 87, when we called him for this, I would say, conference in Ahmedabad, he was quoting the Nadas because he was trained under Dr. Nadas. And he said, he has written one very small book, I think naturally all of you must be knowing, but I kept from those days, Bedside Clinical Diagnosis of Cyanotic as a whole congenital heart disease. And I think very simply, in the language of general pediatrician's understanding, he has described. Many times I tell my student that if you don't tell anything, and that is very small book, probably less than 50 pages. And when you were talking, to be very frank, it reminded me that very simple, these points he was talking during those days also. And thank you very much. At least as I said, I learned a lot. And just I will take 1 minute more. Many times, usually, you know what we are talking, that we are in a small institution, we don't have the facility. That's why we are not probably able to manage the way it should be managed. But we learn the history, then we realize that we are far ahead to these people. When we talk of the Blalock tossing, I think all of you must be knowing because I remember that Dr. Tossing, Helen Brooke Tossing, she lost the mother due to tuberculosis. She suffered from the tuberculosis. And therefore, even her schooling was affected. She had the mild deafness, later on totally lost. And rather than, I will say, hearing, she was perceiving heart sounds with, I will say, fingers. And then what she taught, I will say, to all of us almost 100 years back, still it is true. That means it depends if the person is interested, whatever the limited resources or facility we have, even the technology, certainly we can be the good. But I think it's need of this country that we should be first good clinician. Then probably other things are manageable. Once again, thank you very much. And really, I learned a lot. Thanks to our team, who is every Thursday, I will say, managing for all of us to learn. Thank you, all of you. Over to you, Dr. Nehal.
Thank you. Thank you so much, sir. You always take a good part into the history of each and everything, and we always enjoy listening to it. So thank you so much, sir. And I thank Neeraj for making such a wonderful, having such a wonderfully moderating and making such a wonderful cases with all the panelists. And all the panelists, they are all my friend. But as I said, they are all stalwarts in their field. So thank you so much, Divyesh. Thank you, Jasleen. Thank you, Ravi sir. Thank you, Murtaza sir. So thank you once again, all those who have joined and those who have learned. Charul is there. Charul said she also said it's a wonderful session. So thanks all of you. Thank you, Jalil sir. He was constantly here. Thank you. Thank you so much. Good night, all.
Thank you. Good night.
Thank
Thank
you
you.
all. Thank you.
Thank you.
Thank you. Thank you, everyone. And last to say, I'm also from GMC Surat.
Yes.
Sir, I'm from GMC Surat. So thank you.
Neeraj, yes. Divyesh, GMC, yes.
Neeraj sir started the path and then everybody walked on that path.
Naya Divyesh, that was me. Neeraj
Acha.
got that motivation from me, right?
Oh, I didn't know that story.
Okay, bye-bye.
Bye. Good night, ma'am.
Good night. Good night. Thank you, sir. Thank you, Divyesh, Jasleen, sir.
Bye, sir.
Neeraj,
Bye,
sir.
sir.
Good night, sir.
Bye, sir.